Mayo Clinic has a financial interest in Exact Sciences.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Well, March is Colorectal Cancer Awareness Month, and the term colorectal cancer is used to describe cancer of the colon or the rectum or both. Now, the rectum is that part of the lower end of the colon that connects the colon to the outside. Mm-hmm. Cancer, unfortunately, or colon cancer, is the third most common cancer in the U.S., and it can affect virtually anyone. It's most commonly found in people over the age of 50.
But not always.
Well, you're right.
The number of people diagnosed with colon cancer younger than 50 is on the rise. Joining us to talk about colorectal cancer, risk factors, diagnosis, treatment, and prevention is Mayo Clinic gastroenterologist and colon cancer expert, Dr. John Kisiel. Welcome back to the program.
Thank you for having me back. It's a pleasure to be here.
All right, Dr. Kisiel, this is still the second leading cause of cancer deaths in the United States?
I'm afraid it is. So lung cancer affects both sexes proportionally. Men are more prone to prostate cancer, obviously, and women will have a fair number of deaths attributable to breast cancer. But when you add them all up and average across both sexes, colon cancer is still the second leading cause of cancer deaths in the United States.
And it's increasing?
Actually, it's decreasing.
Okay.
So our efforts at prevention and screening have made a significant impact in colorectal cancer incidence, so the number of new cases that are diagnosed and the number of people who die from the disease are fortunately decreasing with the advent of the availability of population-level screening for the disease. So it should be a success story, but that success is only half full because there are a substantial number of people who are still not getting screened.
Is it true that if you don't smoke, this is the cancer that's most likely to take your life?
That is correct.
And I suspect maybe you're catching up to lung cancer deaths, even though the number of colon cancer deaths is declining, but there are fewer smokers. So lung cancer is less common, dying from lung cancer less common than it used to be.
Fortunately, that is true. So the rates of fatality for lung cancer and colon cancer are both decreasing with screening for colon cancer and with fewer people smoking with lung cancer. Now, that doesn't explain all of the story, but those are very high-level trends.
Screening starts at age 50, but now we're starting to hear maybe age 45, as we said in the intro. Is that just so that you have a head start on catching some of these cancers, or is it because you're finding that people are being diagnosed with it earlier?
So that is a complicated question to answer. Right now, there's very compelling evidence that screening beginning at age 50 will lower the mortality rates from colon cancer. There's some emerging science to suggest that the rates of deaths and new cases among patients under the age of 50 in the United States are increasing, and we don't really know why. Maybe due to trends in diet or other exposures that began with people in the early 70s or late 60s. The national guidelines that look at the risks and benefits of screening patients in many circumstances disagree on this topic. So because the rate of advanced polyps in patients age 49 or 45 to 49 is somewhat similar to what we see in 50 plus patients, the American Cancer Society made a recommendation a few years ago to consider screening patients beginning at age 45 in order to catch advanced polyps and early stage cancers before patients develop symptoms from cancer.
Now, was that in everybody or just people with a family history?
That is for average risk patients, so persons without family history. In patients with family history or for certain high-risk predisposing conditions, such as hereditary colon cancer syndromes or inflammatory bowel diseases, we don't talk so much about screening as we do about surveillance. So those are patients who are at increased risk, and they have customized approaches to cancer prevention in each of those specific settings.
Can we just, as a little offshoot, so if the American Cancer Society says 45 instead of 50, have insurers agreed 45 instead of 50, or are we still in a little limbo land there?
That's a great question. So it depends on who you get your insurance from.
Okay.
The American Cancer Society guidelines are binding to patients who receive insurance coverage on a statewide basis. If you receive insurance coverage from your employer, that falls under federal regulations in which the United States Preventative Services Task Force guidelines are the law of the land.
Let's talk about risk factors, because I think a lot of people are under the impression that if they don't have a family history, they're unlikely to get colon cancer. But in fact, most cases are so-called sporadic, that don't have a family history, right?
That's correct. 75% of all new colon cancer diagnoses are occurring in persons who do not have a family history or do not have a genetic predisposition to get the disease.
Has that 75% is amazing. Has that changed over the last few decades, or has that just been the standard as people have been diagnosed?
I think as molecular genetic testing is advancing, we're starting to find out that some of those younger patients that are being diagnosed may carry a hereditary predisposition that they didn't know about. But we don't learn about that from the family history. We only learn about that in those individuals after they've been diagnosed with the disease. So this landscape may change over time as a broader audience of average Joes out there are getting genetic testing done for other reasons. But for right now, really, we want to screen the average risk person who doesn't have that family history, because that's where the majority of the disease is still occurring.
If you had a close relative, let's say a parent or a sibling, who had had cancer of the colon, when would you start screening, and would you get genetic testing?
So typically the person who needs the genetic testing is the person who gets diagnosed with the cancer. That's where the genetic testing has the highest yield. After that, when we're assessing a family member of that individual, we want to know for your first-degree relative, are they a first-degree relative? So that affected family member needs to be someone close to you, a sibling, a parent, or a child. Second, how old were they when that cancer was diagnosed? So most people in the United States with average risk colon cancers are diagnosed in their mid-60s. When patients are diagnosed at age 60 or younger, we start to worry that that risk is going up in that family and that they may actually carry a predisposing mutation. In terms of the recommendations for you as the family member of that person affected with the disease, we typically would start screening or surveillance in this case 10 years before their diagnosis. So let's say you had a brother diagnosed with colon cancer at age 59. We would either start 10 years before that individual or 10 years before you would have been due to start programmatic screening. So your recommendation would be to get a colonoscopy every 5 years starting at age 40.
All right. Now, if you did have genetic testing, let's say you had a sister who had colon cancer at age 59. Let's say that you're 40 or 45. What can genetic testing actually tell you?
So genetic testing on the affected person, the individual who has the disease, say the 59-year-old sister, if she is carrying a hereditary mutation that increased her likelihood of getting colon cancer, having yourself get tested for the same mutation will tell you whether or not you need to follow the average risk guidelines or whether or not you need to follow the surveillance that's tailored to that disease. The most common predisposing mutation to hereditary colon cancer occurs in a variety of genes that fix damage to our DNA, which writes the structural code of our cellular biology. And those repair enzymes, when they are deficient, there will be proofreading mistakes in that DNA that can lead to unregulated cell growth. That cluster of genetic diseases is called Lynch syndrome and is probably responsible for about 5 to 10% of all colon cancer. Individuals with Lynch syndrome have a very high lifetime risk of colon cancer, and so if you carry that mutation, we actually do colonoscopy surveillance on those individuals every year or two. So it's a big difference in what we would recommend for the average risk population, and it's important for people to know.
When it comes to the risk factors, how long does it take for a polyp to become a cancerous polyp? I assume it's 5 years, because for the general population, you go in every 5 years. Before we get to what the symptoms of colon cancer are, do we have any idea how long a polyp can sit there before it goes bad?
That's a great question. We have several lines of evidence to suggest that that life cycle of going from normal appearing healthy colon tissue to a cancer might be closer to 10 years.
Okay.
Individuals that have hereditary predisposition, like Lynch syndrome I mentioned earlier, they're on an accelerated growth pattern. So if they develop a polyp, it can go bad much faster. There's some old data from Mayo Clinic, from the area of barium X-rays, to more recent data using CT scans to detect colon cancer, that very small polyps, those 5 millimeters or smaller, many of those will actually just go away on their own. And only really about 1 in every 6 of those really diminutive polyps will ever actually progress into a larger polyp that could eventually one day become cancer.
So let's talk quickly about symptoms. And what percentage of patients who are diagnosed with colon cancer actually have symptoms?
Fortunately, few. So probably only about 30 or 40% of patients will actually have symptoms that lead to their diagnosis. And really, you don't want to wait until you develop symptoms of the disease in order to get diagnosed. The symptoms are vague and nonspecific and could be confused with a variety of other things, such as fatigue, abdominal pain, difficulty going to the bathroom, blood in the stool. Usually any of those, when they're present, they could signify something else. If they're associated with colon cancer, usually they're associated with late stage colon cancer that may be either difficult to treat or may no longer be curable. So really that's why we want to encourage screening, which is not identifying the patient who has symptoms, but the person out there on the street who's feeling fine. That person still has a 1 in 20 lifetime risk of developing colon cancer, and we want to prevent that.
All right, well, March is National Colorectal Cancer Awareness Month. Our guest and expert on cancer of the colon and rectum, gastroenterologist Dr. John Kisiel. Time for a short break. When we come back, we'll talk about options for screening, treatment, and prevention. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Our guest is an expert on cancer of the colon and the rectum, Dr. John Kisiel, gastroenterologist at the Mayo Clinic. The one thing we've learned, and probably the most important thing we've learned, is that you want to catch this disease before you have symptoms. So let's talk about screening options. And by the way, Tracy had it done yesterday. And you survived.
I did. It was my second colonoscopy.
And it wasn't that bad, was it?
And as everybody says, it's the prep that'll get you. But I recommend a diet of three days ahead of time instead of just waiting until 24 hours ahead of time.
And why do you say that?
Because then you have less content to move.
All right. But you did the Movi prep? You drank
Yes, Mova prep,
gallon
yes.
or 2 gallons or whatever it was?
I think it was a barge load of Mova prep.
But whatever, it's a lot better than catching it after it's already spread somewhere, and it can kill you, right? So colonoscopy still the gold standard?
Colonoscopy is what we call the criterion standard. So it is the test that all other options are measured up against. It does have some noteworthy limitations, but in general, it's a test that is preferred in most guidelines due to the fact that it can not only identify cancers, but it can identify precancerous polyps and remove them in one step. The other screening options that are available, flexible sigmoidoscopy, really only looks at the left side of the colon.
That's a short tube.
That's a short tube, a shorter scope.
Yep.
It can be combined with some other non-invasive test options for greater sensitivity. The non-invasive options include stool-based tests. People may have heard of the Guaiac fecal occult blood test, or FOBT. There's newer protein chemistry called the fecal immunochemical test, or FIT test. There's the stool DNA test, which combines hemoglobin, which is a marker of blood content, as well as some DNA alterations that we know are found in polyps and cancers.
So that's the Cologuard.
That's the Cologuard test.
All right. And it's caught on.
It has caught on. So by way of disclosure, my laboratory has a relationship with the company that manufactures that test, but I can speak broadly about principles related to screening and test performance of any of the available options.
How accurate is it, really?
So the test is 92% sensitive for curable stage colon cancers and detects large polyps with a sensitivity of 42% in the largest available clinical study. In other studies in the screen setting, the sensitivities may be slightly higher than that. And the sensitivity for polyps increases with the size of the tumor and also its risk of turning into cancer.
So when you say sensitivity, explain what you mean by that.
So of all the patients that have colon cancer, for instance, in the largest scale clinical study, there were 10,000 patients with no symptoms. There were 65 people who had colon cancer and didn't know it, and the Cologuard test detected 62 or 63% of those. So that 62 or 63 divided by 65 is 92%, and that is the ability for the test to pick up a condition when it exists.
And that's where you just have a bowel movement, put it in a box, send it to Madison, and they test it, and you get the result.
So the test is required to be ordered by a physician, and that ensures closed-loop communication of the results. So your doctor gets that result back, and then they need to help arrange for the follow-up that would be required if the test was positive. There's then a patient navigation system that contacts patients to let them know that the test has been ordered and to arrange delivery of the test kit to their home. Patients can produce the bowel movement in the privacy and comfort of their own home, and then it is the United States Parcel Service, or UPS, that arranges for the
brown
test.
truck.
The brown truck brings the white box with brown contents back to a central clinical laboratory where it's processed in automated fashion. So there's no human operator that's trying to interpret the test result. It's all done algorithmically to generate a positive or negative result that's communicated to the doctor. And if the result is positive, patients need to have a diagnostic colonoscopy to follow up that positive result.
All right, and when to stop screening? I know you get that question fairly frequently. When do you stop?
We do. I was in fact in a Mayo podcast with Dr. Chutka, who's a primary care doctor, and he said he gets that question a lot. And it's a difficult question to answer because there really are no formal guidelines that address that question. The major societies on screening suggest stopping around age 75, but we generally tell people if you've got really high quality life, if you're a very healthy individual and have at least 10 years more of high quality life expectancy, that you could continue screening or could continue surveillance if you've been found to have polyps in the past. Where it gets very challenging is when patients have other serious competing health problems. So it's not uncommon for us to see a patient who's been sent for a screening or a surveillance exam who has significant heart or lung or kidney disease that may actually shorten their lifespan. I think sometimes patients and primary care doctors feel pressured into following recommendations that we've charted to say patient has to get another colonoscopy. I think that decision should be held between the primary care provider and the patient to really find out what's best for them.
You only have to do this 20 more times.
Maybe.
We hope.
I have a question about once you've been diagnosed. So you have the colonoscopy, there is a polyp that is cancerous. How do you treat that patient?
So if it's a polyp that has cancer in it, sometimes just removing that polyp could completely remove the cancer. We would then, as long as we didn't suspect that the cancer had grown deeper into the bowel wall or had spread, we would do primarily CT scanning or MRI to answer that question. And then we would follow the patient very closely with future colonoscopies or additional tests if they develop symptoms.
If it has spread, then what happens?
If it has spread, we want to know several questions. Exactly where in the colon or rectum is it? Has it grown into any other local structures? Are lymph nodes, which are the drainage routes of the tumor along blood vessels, are they affected with tumor? And has it spread into distant organs? Typically, patients that have cancer above the level of the pelvis in the anatomic colon will have that primary tumor removed. Lymph nodes can be sampled during the surgical removal to make sure that there's nothing we can't see with a scan. And those patients, if they do have involvement of their lymph nodes, may receive chemotherapy after surgery. Patients who have rectal cancer that has not spread far and wide typically will receive chemotherapy and radiation before surgery in order to shrink the tumor down. The rectum is a smaller and more confined space within the pelvis, so it's easier for tumors in that location to start hitting into some of the adjacent structures there that we want to try to preserve if possible.
And most of the time, these surgeries can be carried out without a pouch, without
a colostomy or diversion of the colon.
Right.
It's situational. With rectal cancer, that's where the risk of requiring a permanent stoma is highest, and that is addressed primarily with an MRI of the pelvis to figure out how close that tumor is to the sphincter muscles. In order to preserve,
that's the little muscle.
That's the little muscles that regulates
Yep.
flow of contents out of the anal canal. And if the tumor is too close to those sphincter muscles, those muscles have to be removed surgically as well. And then there's no way to regulate continence, and an ostomy is required. For tumors that are more than just a few inches, typically 5 centimeters or more above those sphincter muscles, often the long-term continuity of bowel function can be preserved, and patients do not necessarily require a permanent stoma. I think for patients that are concerned about screening, we hear repeatedly that they don't want to get screened because they don't want a bag. And that's a very frightening concept for patients. Again, it's a minority of patients that are diagnosed with colon cancer who will require a permanent stoma and should not be a deterrent to getting screened in the first place.
Finally, it's Colorectal Cancer Awareness Month. So how can we prevent colon cancer? Is it even possible?
It's absolutely preventable. It is described as the most fatal yet preventable disease that people, unfortunately, when they succumb to it, it's often needlessly.
That's why we should have Awareness Month.
Absolutely.
So how can we prevent it?
So be seen by your provider and get screened. Talk about the available screening options that are available to you either through your healthcare provider or are covered by your insurance, and use them in accordance with guidelines.
All right, March is Colorectal Cancer Awareness Month. Remember, it can affect anyone, even if you're younger. The most common symptom is no symptom. Be sure and get screened, catch it early, and you can almost surely survive it. As Dr. Kisiel just mentioned, it is the most fatal, but also the most preventable cancer that we know about. Our thanks to Mayo Clinic colon cancer expert, Dr. John Kisiel. Thanks for being with us.
Thank you for having me.